Is it okay, sir?
Yes, perfectly fine.
Okay. So here
You can,
we are
yeah,
beginning.
great. Go ahead.
Okay. So first of all, on this auspicious day of, uh, we can say, let's start. Okay. So good evening, everyone. First of all, sir, happy Guru Purnima Day. As right now you are our Guru, so I have to wish you.
Thank you so much, Ashish. Please carry. Can you change the slides? It is
Yes.
working, no, from your end?
Yes, sir.
Great. Please carry on.
Is it okay?
It is fine. Yes, fine. Please go ahead.
Okay. Good evening, everyone. So as we all know, we are here gathered for myopia control session. So I am going to start talking about a recent thesis by Priscilla and Pawan Varkichala. Those are working in every PEI as a researcher. So the topic name is Time Trends on the Prevalence of Myopia in India, a prediction model for 2050 for the prevalence for the future. So what was the purpose of this study, or what was the purpose of this prisma? Myopia is becoming increasing commonly, especially among children, and also prevalence of myopia is increasing day by day. So, what was the purposes of this study? The study is aimed to predict myopia prevalence in urban Indian children, and the specific reason to describe the generational effect of myopia in different age groups over the next 3 decades from the year 2020. We are talking about till 2050. Okay. Myopia is a growing global health concern now, affecting India significantly. Urban Indian children, age group between 5 to 15, saw myopic rise from 4.5 percentage in 1999. Up to 2019, it has been increased from 4.5 to 21.5 percentage. As we can see, prevalence is increasing. About 50% of children show annual progression of more than 0.25 diopter and 18% progression of minus 1.00 diopter per year. Early onset increases the risk of high myopia and related eye disease. Example as retinal detachment, optic atrophies, and different. So it also includes economic burden. It includes high cost for correction and treatment with major impact expected in India due to its large population. So, methodology. This is the main methodology. How they did, how they started working, and how this Prisma works. We should start systemic review conducted by using Prisma. Prisma is a 2009 checklist named as preferred reporting items for systemic review and meta-analysis, in which this study is based on by meta-analyzing different group of studies into one. So we can check further prevalence for future. So it is started from searching PubMed advanced search with keywords specifically in advanced mode, myopia prevalence and India, and another keyword search is refractive error and prevalence in India. After using this, we can define different kinds of articles and studies related to our overall 432 articles is identified from the keyword search. Titles and abstract screened for relevance, eligibility assessed based on study, type, location, time frame, and myopia definition. So the study included only population school-based studies conducted in India specifically, published between studies published between 1995 and March 2020. This included studies that defined myopia as spherical equivalent less than minus zero point 0.5 diopter as per International Myopia Institute guidelines. So here is the framework, how it works. Systematic review and prediction model we are going to talk about. The specific systematic review work in 4 points, conducted following PRISMA guidelines, included 8 studies from 1999 to 2019. Total participants were 28,600. All are children in between age group of 5 to 15, urban children group. Literature section criteria includes time frame of 1 January 1999 to 31 December 2019. Inclusion criteria are studies reporting myopia prevalence only. Population children aged between 5 to 15 years of age, urban group populations. So as per systematic review and prediction model, these were the graphical images. This is a graph of overall summary of studies included for analysis based on eligibility criteria. Okay, so two important to find the overall myopia rate in children aged 5 to 15, researchers counted how many kids had myopia in each age group. Then they combined all those numbers and compared them to the total number of children in the study. This gives the final percentage showing how common myopia is in the age range, specifically between 5 to 15. As you can see here, it is mentioned prevalence of myopia among children in different study location, different overall age group, and population based on school. Please have a look.
Any problem, Ashish?
No, sir. Just a minute.
Okay. Okay.
Okay. Let's start with study objectives. The study objective includes prediction future prevalence of myopia, specifically for 5 to 15 years of children, estimation of general impact across different age groups by 2050, prevalence, proposed a national model for eye care strategies in India. These are the three study objectives which are based upon. Okay. So here were the key results that has been shown in this study. Myopia prevalence in 5 to 15 years of children rise from 4.49 in 1999 to 21.15 in 2019. Prediction indicate prevalence will reach 31.89 in 2030, 40% in 2040, and 48 nearby 50% till 2050. An overall increase of 10.53% in myopia prevalence across all age groups is expected by 2050. So here is a prevalence graph represents the prevalence of myopia in 5 to 15-year children range between year 1999 to 2050. As we can see, the prevalence of myopia percentage on the left side and the years in between 1995 to 2050. As we were seeing, the graph of myopia prevalence has been increasing as shown in the graph. Here is a graphical image. Data shows prevalence of myopia in different age group across time period of 2020 to 2050. As we can see, prevalence of myopia based on data from 1999 to 2020 and projections to 2050. So as we can see, prevalence of myopia percentage is on left side and the bottom side age group criteria. So the main prevalence and the myopia progression has been has been seen in age between 5 to 15 years of age group. So after checking up upon the key results, what are the public health implications included? Rising burden calls for national anti-myopia strategies. We should talk about economic impact significant due to treatment cost and productivity loss. Calls for early intervention, lifestyle changes, optical and pharmacological therapies for pre-myopes or the myopes who are just has been identified. So the conclusion, myopia prevalence is on a steep rise in urban India. Without intervention, nearly 1 in 2 children may be myopic by 2050. Urgent need for public health policies focused on prevention and control should be must apply and should be discussed. The important reason discussions. The study predicts that myopia prevalence in urban Indian children aged between 5 to 15 will increase by 48.2 in 2050, growing at a rate of 0.81 percentage per year. The increase is expected to be linear across age groups, resembling trends observed in East Asian populations. As we're talking about the prevalence for myopia, the highest prevalence of myopia is has been checked, has been calculated. The most of the prevalence are in countries like East and South Asia. Almost 80 to 90 percentage among teenagers are myopic. On the second number is China, almost 70 to 80% prevalence in high school kids. And our third number is Korea. Compared to whole Italy, South Asia wide prediction 53% by 2020. This studies focus on urban children in India, thus not directly comparable. Inclusion of rural areas would yield a lower overall prevalence. Rising myopia trend stress the need for early anti-myopia intervention, including outdoor time for children and proven strategies like orthokeratology, atropine eye drops, and contact lenses for the myopia progression to control. Given that the prevalence of myopia in Indians could increase over the next few decades, it is essential to encourage eye care practitioners to begin using anti-myopia strategies in children who are at high risk of myopia progression. Several strategies to prevent myopia and its progression are currently available, with increasing evidence indicating the efficacy levels for myopia control. Orthokeratology, contact lens, anti-myopia strategies can be used with the increasing prevalence of myopia in India, which also increasing the risk of high myopia. It is time to manufacturers and industry to launch products that control myopia progression in India, which is also cost efficient and can be used easily. So what were the limitations of PRISMA? Meta-analysis, the lack of nationwide data and mixed use of school-based and population-based studies are key limitations. So here is my reference to the study. Thank you.
Thank you so much, Ashish. Yeah, I think can you hold on that that graph, Ashish? Yeah, the next one,
Yes, sir.
the next one, the next, and the next, and the next. Yeah, this one. Yeah. So the reason why I selected this paper was there are a couple of reasons, and that is basically the agenda of today's meeting also. Now, the whole world actually woke up to this myopia epidemic because of the report which was published by Brian Holden in 2006 in ophthalmology, where he predicted, or rather, their group, Brian Holden Vision Institute, the whole group predicted that there will be a prevalence of around 52% of the children would be myopic, and almost 10.2 or some number would be high myopes. Now, the if you see, and in my lecture, in my video, I had said that they really didn't have a data from Indian subcontinent, and if you see the prevalence in that particular chart which was there on the worldwide issue, there was hardly any data from India. So this particular study is also not really about the prevalence, but it is a meta-analysis of all the 7 or 8 studies which have been done in recent past. The bulk of the work was done from Dr. GVS Murthy, Dr. Praveen Vashisht, and Dr. Rohit Saxena from RP Center. And they have done 3 studies which are basically on incidence and prevalence of myopia in North India, and especially in Delhi. And there has been a wonderful article from Shankar Netralaya also, where also they have found that the prevalence is definitely on rise. Now, if you see this particular chart, you can see that the prevalence was at around 4.5% in 1999, and it has risen to 21.15% in 2019. So the point which I am trying to make is that myopia is definitely going to increase, may not go up to 40% or 50%, but definitely it is going to increase. We are really not into epidemiology. We are mainly clinical people, and so this is something which is slowly growing, and they have tried to set up. If you see, this is the trend line. These are first study, second, third, fourth, fifth, and sixth, and seventh. So they have tried to set up the trend line where they are trying to tell that if this particular trend continues, it is going to be like this, with the upper graph and lower graph being at the top and bottom, but this is going to continue in a linear fashion. So that is number one, that prevalence is going to increase. Number two is that if at this point of time you can stop sharing the screen, Ashish. Yeah, stop button. I've done that. So, if at this point of time, if we do not understand that we have to wake up to this particular disease, then it is going to be too late, because there are 2 aspects to myopia, and we will see in coming talks, discussions, and videos. One aspect is that a patient who already has myopia, and second is a set of patients who are pre-myopes. Now, to me, it seems very interesting that you can delay the onset of myopia in pre-myopia patients, and that is why we are working so much on myopia patients. Number two is that whenever a patient of myopia comes, we have to understand that there has to be a progression. We are into this myopia control not to reduce myopia, because there is no such drug, no such device, no such exercise, or nothing at all which can reduce myopia. So if a patient presents to us, we have to document his or her myopia, do a cycloplegic refraction, do axial length keratometry, pachymetry, and then we have to keep waiting till the myopia progresses, because if there is no evidence of progression, we cannot do anything, because all the treatments that are at present available are there to reduce the progression of myopia and not really myopia. Myopia is being treated very nicely since last 150 years with glasses, and refractive surgeons are also quite keen, and even the contact lens people are quite keen to treat myopia. They are treating and doing their job wonderfully. This particular series, this particular thought process is only to stop the progression of myopia. So that is number two. Number three is that we have to understand that any patient which is having a predisposition towards myopia, and in coming, I think, chapter 3 or class 3, would be, I think, on pre-myopia. The second class would be on documentation, because I think that holds the key to understanding what we need to document. And once you start doing this in your clinical practice, you would realize which patients are progressing, and gradually you will have more and more experience that this particular patient may progress further. So the third part, which is pre-myopia, is equally important, because all the patients who may progress to myopia, and we know that these patients are susceptible, should be told, informed about the fact that they can progress to myopia. We have to quickly see what is their hyperopic reserve. We have to see what is their, what is their family history, and how much time they are sitting indoors, and all the risk factors, and then try to tell the patient and try to predict that this particular patient. So any patient whom you see, you feel that there is a risk of progression towards myopia, go ahead and measure the axial length, because the fact that you have a baseline axial length makes it completely different from treating that patient the next time if there is a progression in axial length. And always take the same machine. If you are using a optical biometer, IL Master 500, or if you are using AL scan, or if you are using some other machine, you can always take the same machine to take the same reading, because all machines will have a small inter-test variability. So that will be chapter 3. Chapter 4 will be on atropine. We will be talking, I will be sharing the video on atropine. What are the drops available? What are the theories? What are the trials which we have already done? And what next can be the future? And if there are any other drugs. And then there will be a chapter on a class on optical defocus lenses, glasses. And then there will be a talk about ortho K and red light therapy. And finally, we will talk about combination therapies, and then how to set up a myopia control clinic. What are the logistics? Which are the newer machines? Because newer biometers, come to think of it, that now the biometers which are coming in the market are already thinking about, myopia in the mind, and the newer biometers have autoref incorporated into their biometry. See, biometry was a wonderful tool which was available to ophthalmologists mainly for cataract and nothing else. So basically, the ophthalmologists were using biometry to find out what is the axial length for cataract surgery, because that is how we can find out what IOL power we have to implant. And the biometer, now the newer biometers are having a thought process that they should have autoref or autorefractor incorporated into them, so that they can be a single point machine which uses axial length and has keratometry and has autorefraction, and they will have softwares which can predict myopia. So there's a question, how do you define myopia? I think it is quite easy. You can define any myopia which is under cycloplegic refraction. Anything more than minus 0.5 is definitely myopia. How do you define pre-myopia? So that is, there will be a separate talk on pre-myopia, but because there's a question, the pre-myopia is defined based on the age of the patient. So pre-myopia, so a plus 0.5 may not be pre-myopia for a kid who is 15-year-old, but a plus 0.5 may be pre-myopia for a 3-year-old. So the definition of pre-myopia as per International Myopia Institute is any refraction between minus 0.5 diopter to plus 0.75 diopter with appropriate risk factors like familial history of myopia and as per the age. So I will be sharing those particular specific numbers as to what age which particular glass power is called as pre-myopia. So this is known as hyperopic reserve, the plus power which the kid is having, and as per the age. So if there is a sibling who is having myopia, and if parents are having myopia, and if the kid is having plus 0.5 and the age is less than 6 years, this particular kid is definitely into pre-myopia. So we are not here. The most important point is to, every time you have to check for axial length keratometry and cycloplegic refraction. You have to intervene only when you see that child is losing his or her hyperopic reserve very quickly and it is axial progression. So these two things are very, very important, that there has to be a cycloplegic refraction and you have to see that there is an axial elongation, axial progression, because bulk of all our treatment protocols are directed towards axial elongation and nothing else. So whether it is red light therapy, creating differences in choroid, or whether it is about atropine releasing dopamine, or whether it is about peripheral defocus lenses which are creating a myopic defocus, thereby reducing the chances of progression, everything is based on axial elongation. So this one baseline point we have to understand at this point of time is that there has to be a progression, and that has to be documented progression for any treatment of myopia progression, number one. Number two, that particular progression has to be axial. If the progression is lenticular or curvature, like on the basis of curvature of the cornea, or on the basis of movement of the lens, like syndromic children, or like retinopathy of premature children, who actually have crowded anterior segments or have steep corneas and not really a very large axial length, or not really a progressive axial length. So any kid who has school going myopia, that is what we call this particular category of myopia, is school going myopia. And if it is progressing, yes, I think I have talked in the lecture also, or I have talked in this particular lecture that even the height increase is correlated with myopia progression. So all those things which are lifestyle things, if they are associated with myopia, and if myopia is progressing, then that can be slowed down. The most important point here is that you have to overemphasize the importance of lifestyle modification. Lifestyle modification is the key towards everything. So you may have to spend a little extra chair time to the patient to make sure that they have to reduce their near work, they have to sit outdoors, and also the fact that they have to reduce a constant near work, like if they are sitting on screens or reading novels for a very long time, say 1 hour at a stretch, that is not really advisable, and they have to slow down. And to impress upon them that you can give some drug, you can start some glasses, but at the end of the day, the key is definitely lifestyle modification. Near work, indoor sitting are the two most important risk factors, apart from a very long list of factors. I think I would be sharing that article which was published in BMC 2020. I must have talked about it. I can share it on the group also. So that particular article has all the risk factors, and all those risk factors are anecdotal in the sense that going to urban school, or sitting in LED lamps, or reading late night, all these things are not consistent in different studies. But two most important things which are consistent across all the studies are outdoor timing and reduced near work. So these two factors would definitely go a long way in reducing the progression of myopia. So with this, I would like to welcome everybody, and we will be sharing the videos every 7th or 8th day, and then we will be live on Zoom. If there are any questions, we can talk, or we can discuss that also. Yes, Ashish.
I think
Yes, Dr. Shalaka.
sir,